let's begin with, and it won't allow me to even advance my slides. Oh gosh. How do I get, let's try this. Yes, okay. So unfortunately, I have nothing to disclose. I'm going to begin with a headline from an often read medical journal, the New York Times, and it reads, "An overlooked, possibly fatal coronavirus crisis, a dire need for kidney dialysis." And this appeared in the New York Times in April of this year. And the quote from Dr. David Goldfarb was, "The nephrologists in New York City are going slightly crazy, making sure that everyone with kidney failure gets treatment. Nothing like this has ever been seen in terms of the number of people needing kidney replacement therapy," he said. So what are the actual facts regarding COVID-19 and kidney injury? Are we seeing a great number of these cases? Are patients in the ICU having a disproportionately high rate of kidney failure? So we know today we're going to talk a bit about the causes, incidence, and pathogenesis of AKI in critically ill patients. We're going to talk a bit about organ crosstalk, the incidence and types of renal injury in COVID-19 patients. And we're going to ask the question, is renal involvement different in COVID-19 patients compared to other critically ill ICU patients? We'll talk about the significance of proteinuria and hematuria, even in the absence of elevated creatinine. And we're going to talk a bit about the Renin-Angiotensin-Aldosterone system and its role in COVID-19, and briefly, what little we know about therapeutic intervention. So causes and incidence of AKI in critically ill patients. I want to point out on the right-hand side of this slide, there are stages that we talk about when it comes to acute kidney injury, which is different from what most people are accustomed to, the 6 stages of chronic kidney disease. So stage 1 of acute kidney injury is a rise in creatinine of greater than or equal to 1.5 to 1.9 times baseline. Stage 2 would be 2 to 3 times baseline, and stage 3 would be greater than 3 times baseline, or a creatinine that goes above 4, or the requirement for renal replacement therapy. So in a very recent multinational study of over 1,800 patients from 97 ICUs, they reported that AKI developed in 57% of these hospitalized ICU patients within 1 week of admission. Severe AKI, stage 2 or 3, developed in 39%, and I want you to remember that number 39%, and because we're going to be talking about how different that is, if at all, from what we see in patients with COVID, and 13.5% required renal replacement therapy. Those who required renal replacement therapy experienced a mortality rate between 40 and 55%, and by comparison, those in the ICU who experienced an MI had a 20% mortality, those with sepsis without AKI, 15 to 25%, and those with ARDS requiring mechanical ventilation, 30 to 40%. So we know that acute kidney injury has been shown to increase susceptibility to infections, to double the rate of respiratory failure, and directly and indirectly impair cardiac function. So it appears that the mortality of AKI is not primarily due to reduced clearance, which we can generally address with renal replacement therapy, but rather it's due to AKI's association with multi-organ dysfunction. So when the kidneys don't work well, neither do the lungs, the brain, the heart, the liver, the intestine, and the bone marrow. And we're going to touch upon organ crosstalk a little bit later. What are the most common causes of AKI in the ICU? Well, in general, sepsis is the most common cause and generally accounts for the majority of cases of AKI for critically ill patients, but there are a host of other potential causes of AKI, including ARDS at the bottom of this list. This is probably more than you ever want to know about sepsis-induced injury to the proximal tubule, but when the proximal tubule is injured, pathogen and damage-associated molecules cause microcirculatory dysfunction, leading to impaired circulation and increased oxidative stress. Cells in the S1 segment of the proximal tubule secrete tumor necrosis factor alpha and mediators of cell cycle arrest, such as tissue inhibitor of metalloproteinase 2 and insulin-like growth factor binding protein 7. This signals in a paracrine fashion cells in the S2 and S3 segments of the proximal tubule and triggers an oxidative burst that uncouples mitochondrial respiration and leads to the production of radical oxygen and nitrogen species. There's also downregulated apical ionic transport, that leads to chloride accumulation, leading to tubular glomerular feedback and constriction of the afferent arteriole, which helps to shut down the kidney. More than you ever wanted to know about hypotension-induced renal injury. So ischemic injury due to hypotension is a complex process, and it involves direct ischemic insult and a secondary immune response. Endothelial cell injury disrupts microvascular blood flow, and activation of the endothelium by ischemic injury leads to upregulation of adhesion molecules such as ICAM1 and P-selectin, which facilitates leukocyte endothelial cell interactions, macrophage recruitment, and elaboration of chemokines. There is a disproportionate decrease in medullary blood flow, and we already know that that region is always on the brink of hypoxia with, under normal circumstances, PO2 in the 10 to 20 millimeter range. This hypoxia leads to epithelial cell injury, which is generally most pronounced in the proximal tubule and in the thick ascending limb. Poor oxygenation leads to tubular injury through the intracellular accumulation of calcium, the generation of reactive oxygen species, activation of phospholipases and proteases, depletion of ATP and apoptosis, and there is redistribution of integrin receptors from the basolateral membrane to the luminal membrane, allowing damaged tubular cells to slough and also to adhere to one another, causing intratubular obstruction. Damaged tubular cells release intracellular proteins known as alarmin, such as DNA, heat shock protein, high mobility group box 1. These activate dendritic cells, which in turn activate and recruit neutrophils, natural killer cells, and macrophages, the latter two being components of the innate immune system. And an inflammatory and immune response leads to sequestration of leukocytes in inflamed sites and to complement activation. Complement components such as C3a and C5a generated following complement activation bind to receptors expressed on endothelial cells, mesangial cells, and tubular epithelial cells, and thereby trigger a systemic inflammatory response. And during ischemic injury, proximal tubule and kidney mononuclear phagocytes expressing CR5a are markedly upregulated, and they recruit inflammatory cells. There's also activation of the complement pathway, the alternative complement pathway that forms the so-called membrane attack complex, and that may also contribute to renal injury. So I'm going to talk briefly about organ crosstalk because damage to the kidneys has adverse consequences for other organs, including the heart and lungs. I'm only going to talk very briefly about the heart because, as I understand it, you have a talk about the heart coming up in a week or two. But we all know that there is a cardiorenal syndrome, and in fact, there are 5 cardiorenal syndromes. Type 1 is one in which abrupt worsening of cardiac function leads to kidney problems, and type 3 is when abrupt worsening of renal function leads to cardiac problems. Type 2 and 4 are chronic situations, and type 5 has to do with response to systemic disorders. So with cardiorenal syndrome type 1, you get decreased cardiac output, which leads to sympathetic activation and increased venous pressure affecting the kidneys. You can have toxicity that leads to, from agents that you're administering that leads to ischemia, activation of the renin-angiotensin system, BNP and AVP that leads to vasoconstriction, and the release of cytokines that lead to apoptosis and necrosis in the kidney. And the kidney, if it's injured, will also affect the heart. With decreased GFR, you have sodium and water retention, volume expansion, and increased preload. You get activation of the renin-angiotensin system and vasoconstriction and increased afterload. Uremic toxins can affect the functioning of the heart, and you get release of cytokines when you have renal injury as well that leads to apoptosis and necrosis in the heart as well. What about lung-kidney crosstalk in critically ill patients? Well, when the kidney is injured, it does promote ARDS, and it does so through at least 3 different mechanisms. So if we look at the right side of your screen, AKI downregulates salt water transporters in the lung, including epithelial sodium channels, sodium potassium ATPase, and aquaporin 5, which impairs alveolar clearance of salt and water and leads to pulmonary edema. We get upregulations of cytokines and impaired cytokine clearance, which leads to high levels of interleukin 6, interleukin 8, NF-kappa B, ICAM1, and capsase 3, leading to increase in lung T cells, lung neutrophil accumulation, and macrophages, And that in turn leads to inflammation, increased permeability, oxidative stress, and apoptosis in the lungs. And finally, a third pathway has to do with suppression of DDAH, which leads to accumulation of asymmetric dimethylarginine, which in turn leads to nitric oxide dysregulation and activation of oxygen radicals and damage to the lungs. The lungs also, when they don't function well, affect the kidneys. So you get systemic release of pro-inflammatory mediators from injured lung and by mechanical ventilation, such as plasminogen activator inhibitor 1, IL-6, soluble TNF receptors 1 and 2. We know that hypoxemia and hypercapnia reduce renal blood flow in a dose-dependent manner. When we get increased central venous pressure, this may result in increased interstitial and tubular hydrostatic pressure within the encapsulated kidney and lead to renal venous congestion. We get increased intra-abdominal pressure causing renal vein compression, and then we also get increased sympathetic activity leading to renal artery constriction. So then what is the effect of ARDS on the kidneys? What percentage of patients with ARDS develop AKI, separate from those with COVID? So this was a study that was published in 2019, and they looked at roughly 2,400 patients in 459 ICUs from 50 countries. And overall, the rate of AKI in anyone with ARDS was around 39%. And what this study also found was that the mortality rate increased depending upon whether you had AKI and also in terms of how severe the AKI is. So for those who had no AKI, the ICU mortality was around 26%. If they had moderate AKI, it was around 45%. And if they had severe AKI, the mortality was around 53%. And you'll see that these mortality rates are not so different from what we see in patients with ARDS and AKI in COVID patients. So when I was a resident, we used to say that any patient who had a renal consult, an infectious disease consult, and a pulmonary consult had the RIP combination. And we know that this multi-organ dysfunction, especially associated with these three disorders, has a very high rate of mortality. So from this point on, we're going to talk a little bit about what is different about COVID-19 patients and how is this coronavirus different from past coronaviruses. So around 2003, we experienced SARS. And in some ways, SARS is very similar to the coronavirus infection that we have now. It required ACE2 receptors to enter the cells, caused a lot of ATN. Mortality was higher with kidney failure than without. And older age, diabetes, and heart failure were more common in those who developed AKI. AKI was also more common in males. So some similarities, but nowhere near as virulent as the coronavirus we're dealing with now. And over the course of about 2 years, there were about 8,000 cases worldwide. What about MERS? Well, that occurred later. It was around, I believe, around 2016. And worldwide, over the next couple of years, there were about 2,500 cases. I don't believe there was a lot of AKI associated with this. I searched for any descriptions of the AKI, and I found this one study where they looked at 655 publications, and they had to review that many in order to find 12 patients with renal data, which suggests to me that there wasn't a lot of kidney involvement. What we know about COVID-19 in the kidney, however, I should point out, is very limited. It's important to note that we're still learning about this virus, and portions of this talk, I believe, would be quite different 2 weeks from now, and would most certainly be different if given 6 months from now. We do know that the virus generally enters the body through the nose and throat, where the cell surfaces are rich in the ACE2 receptor. In order to enter the cells, you also have to have transmembrane serine proteases. And once the virus has entered the cell, it activates ADAM17, which in turn causes release of tumor necrosis factor alpha, which stimulates IL-6 and starts the inflammatory cytokine cascade. We do think also that binding of angiotensin-2 to the AT1 receptor probably promotes this whole process and may exacerbate the whole problem. Unless the virus is suppressed, it'll progress to involve the alveoli, where the single cell layer is also rich in ACE2. Infection, inflammation, coagulation, and inhibition of heme metabolism, because we know that COVID-19 attacks the 1-beta chain of hemoglobin and captures the porphyrin to inhibit heme metabolism. That leads to impaired oxygen exchange and severe hypoxemia. The illness can become systemic, targeting the heart, brain, gut, kidneys, and vasculature. So prior lung disease is a risk factor, but it doesn't seem to be as much of a risk factor as does hypertension, diabetes, and cardiovascular disease. And what these three disorders have in common is that they're all associated with vascular injury. And one theory holds that organ injury may be initiated by viral infection of the vascular endothelium. We know that there are ACE2 receptors that are expressed on vascular endothelial cells. We also have seen that COVID-19 can directly infect human blood vessel organoids in vitro and human vascular endothelial cells in vivo. And the vascular endothelium is actually an active paracrine, endocrine, and autocrine organ, and endothelial dysfunction will produce vasoconstriction, organ ischemia, inflammation, and a procoagulant state. So how often are the kidneys involved is not yet well established. Early reports from China provided widely varying results for AKI in hospitalized patients, but the percent of AKI was actually lower than we've seen in subsequent reports. And if we look at these 5 studies, the average percent of AKI was only about 11.6%, with most of them requiring renal replacement therapy, 9.7%. If we look at AKI in ICU patients from some more recent data from Europe and the US, the percent of patients with AKI is significantly higher. Probably it ranged from 27 to 85%, but most of the studies found that it was somewhere in the range of 40%, a little, give or take a bit. And if we look at those with stage 2 and stage 3, more serious causes of AKI, again, the data were variable from 8 to 72%. And again, these are from Europe and from the United States and Canada. But on average, I would say we're somewhere in the mid-30s in terms of the percent of patients with AKI. Now, as it happens, just a few days ago, there was the largest study reported to date. And this was a compilation of data collected from 13 academic and community hospitals in the metropolitan New York area between March 1st and April 5th. It involved about 5,500 COVID-19 patients, and about almost 2,000 of them had AKI, or about 36.6%. Of those who had AKI, about 46.5% were stage 1, about 22.4% were stage 2, and 31.1% were stage 3. At the time that they submitted these data, 35% of these patients had died, about 26 had been discharged, and 39% were still hospitalized with their fate yet undetermined. Of those with AKI, about 14.3% required renal replacement therapy. And of those who required renal replacement therapy, almost all of them, 96.8%, were on ventilators. Of those who were non-ventilated, only 21.7% required renal replacement therapy. And risk factors for AKI, not surprisingly, included older age, diabetes, cardiovascular disease, black race, hypertension, and the need for ventilation and vasopressor medications. Of those who required ventilation and developed AKI, 52.2% had the onset of AKI within 24 hours of intubation. So it seems as if when this virus attacks the kidneys and the, attacks the lungs, and the lungs become particularly severely affected, it's also generally around the same time that the kidneys tend to shut down. The true incidence of AKI is hard to know because we don't really have a denominator for how many people have COVID-19. The incidence also depends on the criteria that you're going to use to define AKI. But the incidence of AKI in COVID-19 patients in the ICU is probably in the range of 30 to 40%. Now remember, when we looked at that big study of patients without COVID-19 who had ARDS, they said it was about a 39% incidence of AKI. Renal involvement is likely higher than this among hospitalized patients. In one study among 701 hospitalized patients, at the time of admission, 44% of these patients had proteinuria and hematuria, and 26.7% had hematuria alone. And at that same time, the creatinine was only elevated in 14% of these patients. In a study of 59 patients, 34% developed heavy proteinuria within the first hospital day, and ultimately 63% developed some degree of proteinuria. CAT scans of the kidneys in that particular study demonstrated reduced density within the kidney suggestive of inflammation and edema. So AKI, hematuria, and proteinuria have all been shown to be associated with increased mortality in COVID-19 patients. Here we have a bunch of studies from China looking at increased mortality associated with AKI. And I'll call your attention to the second study down by Zhao in The Lancet, where there were 191 patients with 54 deaths, and 28 of these patients had AKI, and of those 28, 27 died. If you go one up from the bottom, there were 274 patients, 29 of which had AKI, and 28 of them died. We're going to talk in the next couple of slides a little bit about the data in the third study up from the bottom by Cheng that was reported in Kidney International, where they showed more graphically, perhaps, the effect of acute kidney injury on mortality. And this comes from that particular study where they show the cumulative incidence of mortality when patients have acute kidney injury versus those that don't have acute kidney injury. But interestingly, in that study, they also looked at the hazard ratio for mortality, looking at a number of variables. And if patients had proteinuria, 1+ proteinuria, they had about a 2.5 hazard ratio for mortality. If they had 2 to 3+ proteinuria, it was around 6.8. If they had 1+ hematuria, it was around 3. And if they had 2 to 3+ hematuria, it was almost 9. If they had a peak serum creatinine of greater than 133 micromoles per liter, which is a unit that they use in other parts of the world to translate that into a unit that you're probably more familiar with, which would be milligrams per deciliter, 133 would be roughly the equivalent of 1.5 milligrams per deciliter. So if their peak serum creatinine went above 1.5, their hazard ratio for mortality was around 3. Those who developed acute kidney injury stage 1 had a hazard ratio of mortality close to 2. Those with stage 2, it was around 3.5, and with stage 3, it was almost 5. So having proteinuria, having hematuria, having any degree of renal impairment appears to increase the risk of mortality in these patients. This slide actually came from that recent study that was published within the past week of the compilation of data from 13 academic and non-academic hospitals in the greater New York City area. And what you can see is that with no AKI, this bar in the middle, being colorblind, I'm not sure if it's green or gray, but this bar in the middle shows that without AKI, a lot of patients were discharged from the hospital. With increasingly severe AKI, fewer and fewer patients ended up being discharged from the hospital. And the bar at the bottom shows mortality. And if you had AKI stage 3, you had greater than a 50% mortality, very few discharged from the hospital, and a large number still hospitalized, again, their fate not yet determined. So what's the pathophysiology like for AKI? What are the causes of AKI in COVID-19 patients? And is it different from acute kidney injury in other critically ill patients? Well, anytime you're dealing with a patient with acute renal failure, you always have to go back to basics and think about pre-renal causes, post-renal causes, and intrinsic disease in the kidney. When it comes to pre-renal causes for AKI in COVID patients, our experience has been that at least on arrival, that's not uncommon. Many patients admitted with COVID-19 have been feeling ill for a number of days. They've often had little PO intake. They've had high fevers and may have large insensible losses. About 3% present with diarrhea. And on arrival, our experience has been that many of these patients are volume depleted. So it's important on arrival and throughout their hospitalization to assess the patient's volume status. And it's very important to make these patients euvolemic. You have to avoid hypotension and hypovolemia because that will lead to intrinsic renal injury. But you also have to try to avoid volume overload because that'll compromise respiration, which is always an issue for these patients. Aside from volume depletion, pre-renal azotemia may result from vasodilatation, as seen in sepsis. And it can also result from diminished cardiac output, cardiorenal type 1, as there is increasing evidence of COVID-19 inducing cardiomyopathy and myocarditis, which I'm sure you'll hear more about in an upcoming medical grand rounds. As far as post-renal causes go, there don't seem to have been very many cases of this. It doesn't seem to play a significant role in AKI. This is a study that was published out of New Orleans, and they looked at 161 patients with COVID who developed AKI. And they found that AKI occurred in 61% of their ICU patients, 14% of those who were on the floor, and there was a 50% mortality in those with AKI. Now, they claim that 66% of these patients developed AKI due to ischemic acute tubular injury. But this was based on an assumption, maybe a reasonable assumption, because these patients had prolonged periods of hypotension and poor perfusion of the kidneys. And they also had urinalyses that were consistent with acute tubular injury. But aside from that 66%, there were a variety of other causes that they proposed for acute kidney injury. Only 4 patients underwent kidney biopsy, and I'm not sure what prompted them, but I suspect it was very heavy proteinuria. And they found that 3 of those 4 had collapsing glomerulopathy. Now, collapsing glomerulopathy, we're seeing an occasional case report in COVID-19 patients. This is a form of focal and segmental glomerulosclerosis that tends to be more aggressive than your typical FSGS and associated with more tubulointerstitial involvement and more common in African Americans. But in this particular study, 13% of these patients had urinalyses that may have suggested some form of acute tubular injury, but they couldn't find any explanation as to why the tubules should have been injured. So could some of the 66% of AKI cases attributed to ischemic injury be due to the cytokine storm? I think absolutely that may be the case. The cytokine storm results in intrarenal inflammation. It results in increased vascular permeability, volume depletion, and cardiomyopathy, which can lead to cardiorenal syndrome type 1 again. The systemic endothelial injury associated with cytokine storm leads to third spacing of fluid, hypotension, and intra-abdominal hypertension. So some of it probably was due to cytokine storm. What about that 13% for which there was no apparent cause of AKI? Is there a COVID-19 nephropathy? Well, there's precedent for virus-induced renal disease. We know that hepatitis C can cause a variety of renal injuries. Hepatitis B can do that. HIV can do that. And at least in transplanted kidneys, cytomegalovirus and BK virus are capable of causing renal injury. So there may be a COVID-19 nephropathy. We know that the spike, the S protein of COVID-19, binds to the ACE2 receptor, and the S protein is then activated and cleaved by cellular transmembrane serine proteases, allowing the virus to release fusion peptides and to allow for fusion with the membrane and allow entry of the virus into the cell. The co-expression of ACE2 and these transmembrane serine proteases is key to the entry of the virus into the host cells. And a study of single-cell RNA sequencing analysis revealed that podocytes in the kidney and proximal straight tubular cells highly express both ACE2 and the necessary transmembrane serine proteases. Podocytes are particularly vulnerable to viral attack, and injury to the podocytes would predictably result in proteinuria, and some of the studies we talked about previously suggested there might be a 40 to 60% incidence of proteinuria in patients arriving in the hospital. As previously noted, proteinuria is a very common finding. Virus has been detected in the urine of patients with COVID-19. And interestingly, there was a lower incidence of AKI reported in patients coming from the reports coming out of China when compared with reports coming from other countries. This could possibly be due to the way in which things were being reported. But interestingly, single-cell RNA sequencing suggests that the expression of ACE2 in podocytes and proximal straight tubule cells in Occidentals is more pronounced than in Asians, which could potentially translate into a higher risk of AKI due to direct cytopathic effect. So this slide represents an autopsy study of 6 patients in China, which had confirmed severe ATN and lymphocyte infiltration. And you can see the lymphocyte infiltration here. Immunohistochemistry demonstrated accumulation of COVID NP antigen in the tubular cells, shown in here. And on EM, you can actually see the viral particles in the cytoplasm of these cells. There was also an influx of macrophages and NK cells seen in the tubular interstitium, and activation of the membrane attack complex and deposited along the tubules. In a second autopsy study coming from China, 9 of 26 patients demonstrated clinical signs of kidney injury, And the findings included tubular injury again, with loss of proximal tubular brush border, shown on the left-hand panel here, and with vacuolar degeneration, shown in the right-hand panel. There were inflammatory cells in the tubules and in an arcuate artery, seen here. And the asterisks, I should say, demonstrate necrotic epithelium in the tubular lumen. You see that on the left-hand panel. And the arrowheads on the right-hand panel demonstrate erythrocyte aggregates obstructing peritubular capillaries, which was a frequent finding in this study. There were pigmented casts consistent with rhabdomyolysis, and there was segmental fibrin thrombi that were seen in the glomeruli with ischemic contraction seen on the right-hand panel. Again, on electron microscopy, you can see the viral particles in the cytoplasm. And in the peritubular capillaries, there was red cell aggregation and damage to the endothelial cells, looking a little bit like thrombotic microangiopathy. There was also upexpression of ACE2 in the tubules and the podocytes, here in the tubules and here in the podocytes. So these two autopsy studies suggest that the virus can enter the tubular epithelial cells and podocytes and perhaps cause direct cytopathic injury. Viral invasion of the kidneys is associated with red blood cell aggregation in the peritubular capillaries, endothelial cell injury, fibrin thrombi within the glomeruli, and occasional pigmented casts suggestive of rhabdomyolysis. There's also an influx of inflammatory cells, including macrophages, NK cells, lymphocytes, and the activation of complement with the formation of the membrane attack complex, which has been shown to be a component of damage in a number of renal disorders. So this sort of summarizes what we've said about a COVID nephropathy, but it also points out that the interaction between angiotensin II, which may be overactive, and innate adaptive immune and complement pathways and the coagulation system may influence AKI severity and outcome. And so I want to spend a little bit of time talking about the Renin-Angiotensin-Aldosterone system and what that means for patients with COVID. Because early on in this pandemic, a lot of people were calling for patients on ACE inhibitors and on ARBs to discontinue those medications, thinking that they represented a risk to patients for COVID-19. So what we know, of course, about the Renin-Angiotensin-Aldosterone system is that angiotensinogen is produced in the liver. It's acted upon by renin from the kidneys, which cleaves the molecule into angiotensin 1. Then angiotensin 1 can travel through the lungs, where for the most part, that's where it's acted upon by ACE inhibitors. Acted upon by angiotensin 1 to be converted to angiotensin 2. And angiotensin 2 can then bind to the AT1 receptor, which causes vasoconstriction, hypertension, fibrosis, and proliferation and destruction of tissue. Along the way, angiotensin 1 can be acted upon by ACE2 and converted instead to angiotensin 1-9, and angiotensin 2 can be acted upon by ACE2 to cause angiotensin 1-7, and these can bind to the MAS receptor, which does the exact opposite of this, causing vasodilatation, anti-inflammation, and anti-proliferation. So the effects of ACE2 and angiotensin 2 are opposite to one another. We try to influence the adverse effects in a positive way of angiotensin 2 by putting patients on ACE inhibitors or on angiotensin receptor blockers. And the ACE inhibitors will block the conversion of angiotensin 1 to angiotensin 2 and shift this pathway towards substances that will bind to the MAS receptor. Once you've created angiotensin 2, if you use an angiotensin receptor blocker, it will block the AT1 receptors and shift angiotensin 2 to the AT2 receptors, which again has an opposite effect. It's vasodilatory, it's pro-apoptotic, and it's anti-proliferative. So there's a balance between ACE2 and angiotensin 2. And when angiotensin 2 is the predominant force, we get increased pulmonary vascular permeability, pulmonary edema, ARDS. If ACE2 is the predominant force, we get organ protection. And we use ACE inhibitors and ARBs to shift things to favor ACE2. But since we know that ACE2 is a necessary component for this virus to enter into cells, people were concerned that if we're shifting things to favor the increased expression of ACE2, that it might lead to more virus, more patients involved with the virus and more severe cases in the virus. And there were data in mice, at least, to suggest that ACE inhibitors and ARBs might, in fact, increase ACE2 expression. So we know that once the virus enters the cell, ACE2-mediated protection is lost. And so here we see the transmembrane serine proteases cleaving portions of the virus and it binding to the ACE2 receptor and entering the cell, where it activates ADAM17. The ADAM17 then causes release of tumor necrosis factor and produces IL-6 among other cytokines. And then we get a shift in balance when ADAM17 is activated to more of a pronounced angiotensin-2 AT1 receptor effect. And when this ADAM17 also cleaves ACE2, leading to diminished ACE2 receptors, and again, shifting the balance towards angiotensin-2, leading to vasoconstriction and increased reactive oxygen species. So again, early in the pandemic, there was some concern expressed for the well-being of patients on ACE inhibitors and ARBs. But first, I would point out that the effects of circulating ACE2, even if they're increased, even if this is increased for patients on these medications, may be very different from membrane-bound ACE2. And second, data regarding the impact of ACE inhibitors and ARBs on ACE2 expression are actually contradictory. And a recent study suggests that the use of these agents does not alter ACE2 expression at all. That same study confirmed that ACE2 expression is higher in males than in females, which may explain the fact that males are at greater risk from COVID-19. So what we have observed thus far with regard to ACE inhibitors and ARB use in patients with COVID-19, well, in one retrospective study of only 42 patients, 17 were taking ACE inhibitors and ARBs, and the rest were on different forms of hypertensive medication. And the patients in the non-ACE inhibitor ARB group had higher rates of severe infection, 48% versus 24%. The patients receiving ACE and ARBs were also noted to have lower IL-6 levels, higher numbers of CD3 and CD8 T cells, and significantly lower peak viral load than the patients receiving other antihypertensives. And the only death occurred in this study in the non-ACE ARB group. So ACE inhibitors and ARBs do not seem to increase the risk. This is a compilation of 7 studies that looked at this. And if you look in the far right-hand column here, those on ACE and ARBs as an outpatient didn't have any greater risk of developing COVID-19 than those who are on different forms of hypertensive medication. In these next 2 columns, when we look at mortality, the mortality was pretty similar whether you're on an ACE and ARB or something else. If anything, maybe slightly better in some instances for patients on ACE and ARBs. And when you look at severity of disease, again, it was pretty comparable between the 2 groups. In a couple of studies, maybe significantly lower in those on ACE and ARBs. So I think based on the existing data, I would say that there are no compelling reasons to take someone off an ACE and ARB unless you're doing it for other reasons, because the patient is hypotensive or they've developed acute kidney injury. Those may be reasons to stop those medicines, but I wouldn't stop them just because you're concerned about the patient getting more severe COVID infection or getting COVID infection in the first place. So what do we know about patients with end-stage renal disease? Do they get more COVID than others? So most end-stage renal disease patients receive in-center dialysis for 4 hours, 3 times per week. There, they're exposed to staph, and they're in close proximity to immunosuppressed patients because renal failure causes immunosuppression. And these patients are oftentimes older. They have diabetes, hypertension, and cardiovascular disease. You would expect this group, which can't isolate at home, which clusters together in these dialysis centers and has a lot of the risk factors for COVID-19, you might expect a high rate of COVID infection in this group. Most centers have had patients and staff wear masks and have clustered their COVID-19 positive patients. Also, these dialysis machines are fairly bulky, and the patients are, at least during those 4 hours, generally at least 6 feet apart. I found that it was really hard to obtain data regarding COVID-19 infections in this patient population, but I would think they'd be more prone to infection and to develop severe disease. The only real data that's out there comes from a report from the Kidney Community Emergency Response, and this was reported on April 8th. I've been in touch with the Kidney Community Emergency Response Group to ask a few questions. So they reported that there were 2,738 patients who tested COVID positive. I asked how many patients were tested in the first place to come up with 2,700 that were positive, and no one could give me an answer. I asked whether these patients were tested because they had symptoms or fever, and they suggested that it was probably all of the above, and sometimes just routine screening, because these were coming from a bunch of different providers who had different protocols for testing. But of those 2,700, interestingly, 1,200 of them were hospitalized, which seems like a high rate of hospitalization. 44% of those who tested positive were hospitalized, and 305 of them died. So the overall mortality was 11.1%, but 25% of those who were in the hospital. I also asked them whether they've continued to collect data, and they said that they have. I asked if I could have access to these data, and I was told that only with the permission of CMS, because CMS was not releasing these data. So we contacted CMS, and they sent us an email saying that they would release data with a written request, but only to selected federal and state agencies. So unfortunately, they're not releasing the data as to how often patients with end-stage renal disease develop this disease and how they do with this. Hopefully someday we'll have more information. What about COVID-19 and kidney transplant recipients? Well, there's a registry that's been created at the University of Washington. And again, they're not releasing these data just yet. As it happens, this coming weekend is the annual American Society of Transplantation meetings, national meetings, which will be held online. And my guess is some of these data will be presented this weekend. But if you look at the literature, there are 4 reported studies with relatively small numbers of patients, inpatient and outpatient. AKI seems to have occurred in about 30 to 40% of these patients, transplant patients. Some people have argued that the transplant patients, because of their immunosuppression, might be at less risk of cytokine storm. Although I must say that most of these, from what I can see thus far, most of the patients who, and this was on a forum, most of the patients who got admitted with COVID immediately had their antimetabolite, such as Myfortic or Cellcept, discontinued. And if they were truly sick, oftentimes had their calcineurin inhibitor discontinued. Somewhere between 5 and 17% of these patients required renal replacement therapy. And all of these numbers represent follow-up for 7 to 21 days. The mortality rate varied from 5.6% up to 36%. Again, I suspect that sometime soon we'll have better information about this patient population. What about dialysis in COVID-19 patients with AKI? The indications for dialysis are really no different for COVID-19 infected patients. There appears to be a higher rate of clotting of filters in COVID-19 patients, which, given their hypercoagulable state, is not terribly surprising. In our experience, the need for renal replacement therapy often arises in intubated patients on pressor support, and therefore I think our experience has been that CVVHD has been the most common type of renal replacement therapy. In those who've required intermittent hemodialysis, we've oftentimes limited the treatment to 3 hours and only twice a week to limit exposure of the staff. Just some other potential mechanisms of kidney damage, systemic effects, primarily regulating volume status. When we talk about organ crosstalk, we need to make sure the patient is well oxygenated. We may need to dialyze the patient. They may need LVAD support or even ECMO. And when it comes to cytokine damage, there are cytokine blocking antibodies such as tocilizumab that blocks the interleukin-6. And there are also some filters that will both remove virus and cytokine. So these filters can be put in series with a dialyzer, or in some studies have been used in patients who didn't require dialysis. There are 3 major filters. There are several others on the market, which remove either cytokines or viruses and bacteria, or both. There are a bunch of studies being done, mostly in Europe, but there are some in the US and in Canada. Again, I reached out to people trying to get some information about what the preliminary data show, and I've not been able to get anyone to share these data with me. The CytoSorb, interestingly, is produced by a company right here in New Jersey, and I reached out to the CEO of that company, who has not returned my call, although I did hear from the some other representatives of the company that they were not at liberty to release any information about how this is working. I will tell you that when they've used this with cytokine storms in just routine sepsis, it clearly does remove cytokines temporarily. But I don't think there are really good data to suggest that it has altered the natural history of the disease and changed outcomes. So I would say in summary, there are more questions than answers at this time. I would say that renal involvement characterized by proteinuria and or hematuria is fairly common in hospitalized COVID-19 patients and probably carries an increased risk of mortality. AKI is probably seen in 30 to 40% of all COVID patients in the ICU and can be caused by hemodynamic change, the cytokine storm, organ crosstalk, and possibly by direct viral invasion of the kidney. Whether AKI occurs more often in critically ill COVID-19 patients than in critically ill patients without COVID-19 infection is unclear. The rate of AKI and mortality is high in both groups. And that New York Times headline with which we began this morning or this afternoon may simply reflect the overwhelming number of patients with COVID-19 rather than a higher proportion of such patients with AKI. There is a large multi-center study in progress to learn more about renal involvement in COVID-19 patients. The PI for this study is Dr. David Leaf at Brigham and Women's Hospital, and we are one of the sites. Our co-investigators here are Drs. Puri in nephrology and Dr. Radbell in the pulmonary critical care group, but I was told no information can be disclosed at this time. It seems likely that the virus is capable of direct viral invasion of the kidneys, causing damage to the tubules and podocytes. I think most cases of AKI are probably due to more traditional renal insults seen in critically ill patients. Existing data suggests that the use of ACE inhibitors and ARBs does not increase the risk of contracting COVID-19 or predispose to more severe disease. And whether renal involvement and outcomes are different in solid organ transplant recipients is unclear. Whether the rate of COVID-19 infection in end-stage renal disease patients is greater is unclear. In those patients who've survived this, the long-term consequences of renal involvement is also unknown. We do not know whether renal injury initiated in this way will lead to progression to ESRD. If it does, we're going to be seeing a lot more dialysis patients in the months ahead. Potential therapeutic intervention at this time is fairly limited. Early on, you can use antiviral agents such as remdesivir, along with anticoagulation. It's important to maintain renal perfusion and oxygen delivery to avoid renal injury, and so you can use potentially cytokine inhibition or removal. Not clear yet whether that is going to have a positive impact. And of course, you can provide renal replacement therapy when indicated. So I'd like to end and say that for our junior colleagues, medical students, residents, and fellows, who after graduating from college are asked to endure another 9 to 13 years of grueling training, made worse by this pandemic, and who at times must be wondering what they've gotten themselves into, I'd like to end with the dedication that appeared in the first edition of Harrison's Principles of Internal Medicine, and I ask that you please pardon the gender bias. So no greater opportunity, responsibility, or obligation can fall to the lot of a human being than to become a physician. In the care of the suffering, he needs technical skill, scientific knowledge, and human understanding. He who uses these with courage, with humility, and with wisdom will provide a unique service for his fellow man and will build an enduring edifice of character within himself. The physician should ask of his destiny no more than this. He should be content with no less. And I thank you very much for your kind attention.
Wonderful. Thank you so much, Dr. Mann. I appreciate it. That was fantastic. I'm wondering if anybody has any questions or comments that you wanted to share with Dr. Mann. You can post them on the chat, send them directly to me, and I can pose them to Dr. Mann. maybe while we're waiting to see if anybody has any other questions before we disperse, I was wondering what, I doubt there's much in the literature, but wondering what's been done here to try to limit the spread of at least known COVID-19 from patient to patient who are in dialysis or from patient to provider who are in dialysis.
So especially in the outpatient setting, it differs a little bit. We follow patients at 13 different outpatient dialysis centers. And at different centers, they do different things. But most places are checking temperatures. They always have, in fact. Most patients are being asked to wear a mask when they arrive. They're not being clustered in the waiting room any longer. And the staff, of course, are being checked regularly and are wearing masks. So, and then if somebody tests positive or has symptoms, they tend to cluster them on a particular shift on a particular day so that they're not exposing them to other renal failure patients. And here in the hospital, it's harder. If you have someone in the ICU who's got COVID-19 and needs renal replacement therapy, we try to minimize the exposure to the staff of doing dialysis, but it's really hard. You can use longer lines. You'll have a little more problem with blood flow and resistance to flow, but some places have actually placed their dialysis machines outside of the room and used longer blood lines.
Great. Well, I don't know if there's a question right here. And this is, a question is, are urine samples taken upon admission? And I assume they're asking, this person is asking specifically about known COVID patients. And if not, is there any consideration to start getting this information given the relationship between proteinuria and hematuria and patients' increased risk of worsening outcomes?
So I think that most patients who are admitted to the hospital with COVID probably are having a urinalysis performed. I don't know that for a fact, but I suspect almost all of them are.
And any consideration to looking at this either retrospectively or prospectively to get more information about the relationship between proteinuria and hematuria and outcomes?
I think that would be a great study to do. And I'm not sure if the study that's being directed by Dr. Leaf, whether they're looking at that or not. I don't know.
Great. Well, this is a medical student who posed this question, and I have this medical student's name, so I can hunt him or her down and send you her information.
That would be great.
All right, fantastic. Well, in the meantime, if there's people can post any more questions, but I want to thank everybody for showing up. Next week for Grand Rounds, we're going to have a special Grand Rounds in which it's going to be our Trainees Research Day. So all of our fellows and residents and interns have submitted their abstracts. We are meeting, actually today, a group of us are meeting to review the abstracts and to choose 3 or 4 oral presentations. So the schedule for next week from 11 to 12 will be a virtual poster session where all of the posters and the abstracts will be posted live as part of the Grand Rounds. And then from 12 o'clock to 1 o'clock, we'll have the oral presentations for the selected presenters. And then we'll, subsequently the following week, we'll have a morbidity and mortality conference related to COVID-19. And then the following week, we'll have the Division Chief of Cardiology, Jim Coromillis, who will be giving us a presentation that Dr. Mann alluded to a few times.
I'd also like to thank Dr. Cohen very much because I had all sorts of technical problems this morning, and this talk could not have taken place without his kind assistance.
My pleasure. Thank you all. Stay safe.